Hello, everyone, and welcome. It's 8:30 p.m. in the U.S. Eastern Board in Miami, New York, and Boston. It's 8:30 a.m. in Singapore. We will give it about a minute or so before we start our program tonight. My name is Gilberto Lopes. I'm a professor of clinical medicine at the Sylvester Comprehensive Cancer Center at the University of Miami in Miami, Florida, in the U.S. And today I have here with me Dr. Narjust Duma, who's the Associate Director for Equity at the Dana-Farber Cancer Institute in Boston, part of the Harvard School Medicine Teaching Hospital and part of Harvard University. And we also have a small change. Dr. Lovely had an accident. Christine is doing okay, but she won't be able to join us. So we invited Dr. Tan Min Han, who's a GU oncologist who now works full-time with liquid biopsy and molecular testing. He is the CEO and medical director for Lucence, which is also sponsoring the event tonight. This was a last-minute change given the complications we had with Dr. Lovely, and given that Dr. Mok won't be able to be here at the panel. He will still deliver his lecture, but this has been recorded because he also had another event that he could not get out of today. And as it is 8:31, let me just ask for our technical support to see if we have most of the people who registered coming in. If not, we'll give it a minute. A couple of housekeeping items. We do have a Q&A box, so if you have any questions that you have not yet submitted, please do go ahead and do so through the Q&A box at the bottom of your screen. And we also would like to remind everyone that any images or any talks that are presented are copyrighted with the author and should not be reproduced or used without the author's written confirmation acceptance. And as it's 8:32, I'm going to ask the technical team to go ahead. And Professor Tony Mok has a recorded talk on current and future uses of molecular testing, and he will introduce himself as he starts to speak as well.
Good day. I'm Professor Tony Mok from the Chinese University of Hong Kong. Thank you for the great opportunity to share with you virtually to talk about the present and future trend of molecular testing on lung cancer. To start with, I would like to thank my good friend Gilberto for inviting me to participate. Sorry that I cannot join the discussion due to a conflicting event, but I would like to share with you my view on this in this regard. So first of all, this is my disclosure. More specifically, I'm on the board of directors. There's 3 companies: AstraZeneca, China, and also Genomics. Now, what is the basic principle of molecular testing? And I think it's actually biblical. Well, it's biblical in a way that Matthew 7:7 say, "Seek and you shall find." Like all the biomarker, if you don't look for it, you will not find it. So it's our job as a doctor to look for the biomarker. The question is that, what should we be looking for? What are the biomarkers that we must make it available, and at what time frame? So this is the paradigm that we still have in 2021. It's still relatively simple, but you can see that we have the targetable oncogene and some patient without a targetable driver oncogene. And then under the target oncogene, we have EGFR, ALK, and uncommon mutation. And of course, there are the immune biomarkers that guide us therapy, but this will not be in the arena of my discussion today. So start off with my favorite gene, EGFR mutation. Now, if you have one patient who walked in the door, we probably start to ask the first question: can we find the EGFR mutation such that we can treat it with the TKI? But once we treat it with TKI, there's occurrence of resistance. So during the process, we ask the question: can we monitor the process of response with the EGFR mutation in the plasma? And then at the time resistant, then we have to look for T790M mutation or other resistant mechanism. So briefly talk about how can we use this as a diagnostic test. Now, the classically patient with a radiological abnormality, they need to have a bronchoscopy biopsy before they have the diagnosis of lung cancer and then refer to oncologist. Depending on where you are, it sometimes can take up to weeks to months. But if you do the EGFR mutation testing after you see the oncologist, you further delay the treatment paradigm. However, if you actually start early, even before the diagnosis of lung cancer, you may be able to get answered. In located like Asia, where we have a high incidence of the mutation, should we do it earlier? And how accurate is that? This is one of the earlier work using a plasma-based DNA in the FASCO study. We were able to demonstrate concordance of about 88%, sensitivity of 77%, and specific 96%, meaning that we can catch 3 out of 4 patients, and what if it's positive, we're very confident that it's truly positive. Look at all the pool analysis. Sensitivity is variable, but specificity is actually relatively high. So it gives us a confidence that a positive test is an accurate test. However, if you look at plasma and tissue, there are actually not too much different in terms of cost if you use a single digital PCR or other PCR-based method. And then the false positive rate is also low in either case. So the first question is asked is that, what is the best timing of the mutation testing? Should we use a plasma to use it before the histology? And then, only if it's negative, then you can test the tissue for the mutation. So the one point of discussion. And then on the resistance situation, T7IM, of course, is the main one, but there are other resistance mechanisms as well. This pie chart is actually partly based on the Garden 360. And you can see that T790M is the first and most common mutation for the patient that has actually the first and second generation TKI failure. But then when you fail osimertinib, MEK amplification seems to be more common. But of course, there's still a large number of patients that are being unknown. So the question is that, can we do something about it? Well, before then, we're arguing, but then I think the Titan study from the WCLC this year has shown some insight. And in a way, it's for patients who are MEK amplificated, but identified by one of these 3 diagnoses, either by FISH, IHC, or NGS. Then they go into 3 different cohorts of part B1 or the prior first generation TKI, and then part B2 is the one with no prior third generation TKI but T7 negative, and then no prior TKI, third generation TKI and T7 positive. And part cohort D and part of B2 are actually similar, except for the fact that the sufinitinib is at a lower dose. But for that, you see that for part A, that you actually have a response rate of 33%, which is great. You fail osimertinib, but then you use the combination of osimertinib with a MEK inhibitor, you actually end up 33% response rate. Part B3 is not something surprising because they are T7 positive. They are after failing first, second generation, you will get your response rate of 67% anyway with single agent. But then the curious thing is that even when you're T7 negative in either part D or B2, and then as long as the MEK positive, you combine with the MEK inhibitor, you actually get a response rate of about 62 to 65%. And that is quite impressive. And that is also translated to the median progression-free survival of about 11 months and 9 months in these 2 cohorts. Now you compare to the IMPRESS study, that is on chemotherapy after TKI. When you're T7M negative, your median progression-free survival is 5 months to 6 months. So there's a potentially, this combination should be better than standard chemotherapy. So the next question is that, are we justified to perform NGS in all osimertinib failure? Since we need to look for the MEK, but there are others that we may or may not be able to find target is, how are we going to justify using NGS? Or should we just look for MEK only by looking at the FISH? So I think, in a sense, is that the role of NGS is commonly used in the United States, but across the world, what is the role of NGS in osimertinib resistance? Moving on briefly on ALK. Now, ALK, the first question is that we have the FISH or the IHC as a standard, have been accepted by FDA. So do we need confirmation? Once the IHC positive, do we need FISH confirmation before you move on? And this is actually the very common standard is the IHC positive, that we go right on to the TKI. So what happens if there is patient who are IHC positive and FISH negative? Now, this is actually interesting. In the ADDICT study, we actually identified 13% of patients who are actually FISH negative, but IHC positive. And that is not the same. It is not the only one. In the EXALT-3 study, there's also the patient randomized by IHC, but then the ITT population has to be centralized to become FISH positive as well. But out of that, 43% actually was FISH negative. So if you do the calculation, 14.8%. So approximately similar to Alex's study. And then if you go back to even the profile 1014, you get 14% of patients who had the discordance. So we're always looking at the discordance of FISH negative, but actually positive in this regard. So what happened to this patient in Alex is that their progression-free survival is not that impressive. And also the response rate is only about 30 to 40%, much lower than what you expected when they are both IHC and FISH positive. And then we take further step to look at what happened with the next generation sequencing. And interesting enough, of the 35 patients that we were able to do NGS, 20 of them actually had no ALK fusion identified. But one further interesting point is out of this 20 patients that had no fusion, 10 of them actually have some kind of response or stable disease. So this just reflects that possibility there's a rather heterogeneous situation in some of the ALK positive cancer. So given that, what's the role of plasma tests? One of the best results come from the BFAST. This is actually a so-called plasma-based genome profiling. And then there are multiple cohorts. One of the cohorts is the ALK positive patient by plasma DNA NGS. Then it was actually given the single arm study of about 7-8 patients, about 600 milligrams of anti-BD. And then the pickup rate is actually about 5.4%. So that is similar to what you would have expected on the incidence of ALK positive in the general population of lung cancer. And for that, we actually get a response rate about 80% in the patient with no brain met, and above patient with brain met is about 90%. So that gives you the response rate that is well deserved of a imatinib. But then the question is that when should we use it? What is the role of plasma NGS while it's actually not an FDA approved diagnostic test? Should we be only confined to the patient without the tissue? But then since I show you the discrepancy between FISH and IHC, is there any additional role for this group of patients? So I think it would be an interesting discussion in this regard. Now, another potential application of the plasma base is the predictive value. So in the Alex study, we actually look at the cfDNA as a predictive survival. And certainly the blue line is the imatinib that actually have the cfDNA less than the median, as compared to the crizotinib less than median is still in improvement. But the light blue line with the dark blue line is the one with the more than median of the cfDNA. So therefore, the more cfDNA that you have in the plasma, then actually you get the worst of the prognosis in terms of survival and the progression-free survival. Alex study will show that, and this year ASCO in the Crown study, they showed a very similar performance of the fact that patients who are clearance of the plasma-based DNA, they actually end up with the best survival, whether it's in norotinib arm or in a crizotinib arm. So the question is that, should we use the cfDNA in the plasma as a predictor of outcome in the future? Is there any clinical value in this regard? Another point of discussion. Now, when it comes to resistance, you all know that there are multiple potential ALK-based resistance, and each one of them may have slightly different behavior. And depending on what kind of TKI you got, and then potentially you got different incidence of the G1202R. And we all know that G1202R are the one that is mostly resistant to the second generation drug, and they're more sensitive to the first generation norotinib. And also the time is also different. Ella demonstrated that this is a dynamic event. It's not actually a single event when this ALK point mutation that occur. And also Kristen Lovely has showed that maybe different drug has a different sensitivity with a different mutation. So that leads to a logical question is that, when we want to look into the situation, are we going to use the ALK mutation type to decide on select the second line TKI? Another point worth your discussion. Moving on, last but not the least, is the uncommon mutation. Now, the uncommon mutation, is actually not that uncommon. This is actually based on the Sloan Kettering impact data, over 6,000. So each one of them is about 1 to 3%. However, when you add them up, it's actually about 14.5% that you'll find one of this uncommon mutation. But just a minute, This is a Caucasian-based population. And then if you remove the EGFR mutation and the ALK, which we usually identify right off the bat in all patients, then actually you may have about 21%, 1 of 5 patients, once you exclude the EGFR ALK being negative, then you may end up having one of the uncommon mutation. So I'm sure you love this. When you go to a Chinese restaurant for dim sum, you order 1 dim sum. The question is that, what is your strategy in order dim sum? You order only the one you like, just like EGFR, you just order one you like, or will you order a panel dim sum and select from it? Now, those are the 2 different strategies, a dim sum panel that you can find what you like to eat among the many you order. But of course, you order many, the cost is higher. But do we need all this dim sum? Do we need all this genomic data? Well, to summarize that, there are approved indications. The approved indication for the ROS, BRAF V600E, MEK protein skipping, and RET, there are multiple approved drugs. I don't have to repeat the detail for you because you actually know the information quite well already. The question is that there are additional emerging targets. Just briefly to highlight them. Of course, that we had problem targeting the KRAS before, but now with the specific G12C pocket, then there is a drug, AMG 510, that we're able to target very specific the G12C in the cystine 12 position. And then the COVID 100 study that was actually presented in WCLC and then in ASCO this year, which is a kind of like a important study because it changed the dynamic on sotorasib, well, AMG 510. And then we got response rate of 37%. And then the most updated data from ASCO showing median progression-free survival of 6.8 months and overall survival of over 12.5 months. Very nice in the sense that we don't expect this kind of outcome in a KRAS positive patient. And more than that, May 28, the FDA had given a approval for that as a second-line therapy. Now, and then there's a ERBB2 mutation, which we know that in breast cancer is a significant driver. And then in lung cancer, it is also a driver. However, the inhibition of which is actually been a difficult task. Now, until lately, there is actually not specific drug for the ERBB2, but then the most recent work is from the DS8201 or Enhertu, which is a antibody drug conjugate with the linker tied into a very potent topoisomerase inhibitor, that's the toucan. And for that, in this Destiny-01 study, they looked into the HER2 mutation group of about 42 patients. And with that, they reported a response rate of 62.5%. And there is a median progression-free survival of 14 months and an overall survival not reached. That is quite impressive data, that's suggesting that we're able to hit the target nicely. So this is your minimal dim sum panel. ROS1, BRAF, RET, MEK protein skipping, possibly ERBB2 and KRAS G12C. So even though you do not want, to have all the dim sum that you want, but you need at least 6 dim sum to go with, apart from the EGFR ALK. So the question is, how do you find it? Now you can do it one at a time, but that is labor intensive, potentially costly, and also that it may potentially have this exhaustion of the tissue sample. So comprehensive genomic profiling is the way to go. Those are the terminology to cover either a targeted gene panel, whole exome sequencing, and whole genome sequencing. Of course, most of the time in the clinic, we're talking about a targeted gene panel. It can be either on tissue or on the liquid. Now, the potential benefit. Potential benefit is that basically, you may cover all the relevant genes, EGFR, ALK, and the 6 uncommon mutations at one go. So you don't have to think twice. And then the turnaround time is most of the time that is actually acceptable, about 10 to 14 days. And also, it has actually the potential, to change your first-line treatment. So that is the good thing about the so-called comprehensive genome profiling right off the bat at the first line. But there's also the pitfall. Now, you may find the gene that's clinically irrelevant, in a way that you don't find AM30, you find TP53, the patient was hoping for it, then it's actually, you cannot explain the patient. Or you may find oncogene that's potentially useful, but only in phase 1, but then G12C was just approved it. However, it may not be accessible in many parts of the country. United States may not be a problem, but outside United States, there could be a problem. So we have to consider that to tell the patient saying that, yeah, you find a gene, the drug is available somewhere else, but it's not available to you. It's not easy. And also the genes that are actually with debatable relevance, then you really do not know what to do with it. So overall, I think knowledge is good, but sometimes additional knowledge can bring you a little bit of difficulty trying to explain what your action is going to be like. Right now, on the plasma side, right now there's a Garden 360 that Lucien study that if I look into it, basically most of the parameters are quite similar. And of course, that this is the price that is kind of based in Asia. I don't know what the price is going to be like in the United States, but overall, that I think those are the two comparable panels we can consider if we go for liquid biopsy. So the question is that, what is the optimal strategy to use liquid biopsy? Now, when tissue is available, should we use tissue, or should we use tissue and liquid together, or only with tissue fail, or if you got insufficient sample for the tissue, then use liquid? I think we need to formulate an adequate strategy in adoption of the liquid NGS into our clinical practice. So allow me to summarize. I think the EGFR mutation, the cfDNA is potentially applicable, even moving up the diagnosis earlier for our patient. And then overall, we can use it for diagnosis, monitoring, and resistance. For the ALK translocation, I think the IHC and FISH may stay, but then I think moving on, the liquid biopsy in ALK will be functional. And also, it may help us to define some of the empirical case about FISH and IHC if there's discordance. And the other important thing is that we have to understand whether we can use the cfDNA as a predictor for the treatment outcome. For the uncommon mutation, we get at least 6 target genes we need to be aware of, preferably in first line, but at least during the course of treatment, such that we will not miss the potential target for the patient. And for this point, I think NGS panel is actually one comprehensive way, but whether solid or liquid, that is also come to a debate. So thank you again for the invitation. And again, it was a great pleasure to participate in the discussion in the future. But last but not the least, I want to share with you that not just the genomic panel, any kind of food panel, I would love to participate in. Thank you very much for the time. And certainly, I hope that you have an excellent discussion coming up. Thank you.
All right, we are coming back online. Here's Dr. Duma, here's Dr. Tan, and myself. I'll thank Dr. Mok again extemporaneously. I'll send him an email to thank him for the presentation. And he does leave us with a number of different things for us to open up and to discuss. He went through a historical and general perspective on molecular testing in non-small cell lung cancer. We're not talking about small cell. We could discuss some of that in Q&A session, but of course, that's not where the brunt of using molecular alterations is in lung cancer today. Mostly what we use is actually testing in the advanced setting in metastatic disease, although of course now, at least in the US, we're moving earlier to adjuvant therapy, at least with EGFR mutations, and we might soon do even more things. So we saw Dr. Mok discussing some of the basic aspects of molecular testing today. The tissue testing continues to be the gold standard, but that liquid biopsy or testing for DNA in the blood is quickly becoming either a complementary or something that can substitute for tissue. And that's part of what we're going to be discussing in the next few minutes or so. So if you have any questions, don't be shy, do send them through the Q&A box. Dr. Duma, how are you approaching doing molecular testing in both of your institutions, the institutions where you're coming from, Wisconsin, and the institution you're going to in Boston? What's your usual approach on your regular clinic?
So I have 2 clinics, and one clinic is dedicated to women with lung cancer. So that clinic is a little bit more downstream, and usually they get early referrals or second opinions. So I had a nursing staff that we assure that these women have tissue and liquid biopsy. So we do it at the same time because the sample of the patients were younger women. The majority were never smokers. So the incidence of target mutations was very high. And we had a plan B, which is the liquid biopsy, because 50% of the patients were second opinion. And here in the US, trying to track down tissue from a different part of the country can take weeks. So liquid biopsy really allowed me to get to know these patients by the time we were getting the tissue from somewhere. So that has been very helpful. For out of that clinic, I have similar approach. It's just I tend to go with tissue first. If the patient, doesn't scream that they may have a target mutation for ethnic background, a smoking history, or presentation, I may do tissue. But I have to say that thanks to liquid biopsy, I was able to treat and diagnose patients during the pandemic because I allow for travel phlebotomists to come to my patient's house. I used to practice in Wisconsin, so some of my patients are 200 miles, 150 miles from the cancer center. So, ask them to come was very challenging. So liquid biopsy really helped in the peak of the pandemic for that. And finally, I have to say I'm a big proponent of monitoring some of my EGFR patients with EGFR lung cancer with liquid biopsy, because I have learned and I have prepared them when the time of progression comes.
Thank you. And this is the practice that we have in Miami as well and across the country. What has become more and more common is that quite often we can get results for liquid biopsy very fast, depending on the provider. And the largest providers in the US today are Guardant, as Dr. Mok mentioned, as well as Foundation Medicine also has a liquid biopsy platform. And we have a number of new platforms coming through like Lucence and a number of others. And we have started to have a practice of actually doing things at the same time, because it does still take us, because we use vendors as well for the tissue, same Foundation or Caris being the two most common, but Genoptics being, for instance, a third company that does that as well in the US. We do take about 3 weeks to get results for tissue. And sometimes for patients that clearly we see mutation in the liquid testing, we can be sure that you have a very high specificity. And if that test is positive, it clearly shows you that you have that mutation, and you can feel comfortable to go ahead and actually do the treatment. And there's rare occasions when we might start chemo while waiting because patients cannot wait, but usually 1 week, 10 days is very reasonable to wait for most patients. And one of the first questions we have here by Dr. Wayol Tan from Singapore. Congratulations, Prof, on your National Public Service Award in Singapore as well. We haven't seen each other in person in a while. The question is if there's discordance between liquid and tissue NGS in lung cancer. And the discordance, and that's the point I was coming to, is more on the sensitivity side. So when we do not find a mutation in liquid biopsy in NGS looking at DNA in plasma, then we don't know for sure if there is or not a mutation. And those patients, we absolutely rely on tissue to give the best chance of finding a mutation or not. There are situations where tissue might be better. There are situations where liquid biopsy might be better. For instance, tumors can be heterogeneous. When we sample different metastases, you might have differences, slight differences. When we talk about EGFR, ROS1, and a number of other driver mutations, they tend to be very early phenomena, so that usually doesn't change that much. But when we start talking about resistance, that's something that we might see differences as we move forward, so liquid biopsy may become even more important. And Prof. Tan has a second question in terms of getting tissue being.
Can I add something that there, Gilberto?
Absolutely. Absolutely.
So I think with my experience with patients with target therapy, particularly with patients with ROS1 disease and ALK disease, they tend to have CNS disease and thoracic disease. They don't have a lot of extrathoracic disease compared to patients with EGFR mutations or other mutations. So with those cases, when there's mostly CNS metastasis in primary lung, I tend to have more false negatives with liquid biopsies, because we know the circulating tumor DNA for the brain metastasis, even if the patient has 10 brain metastases, it's not the same. But it doesn't mean we stop there, right? We need to get still the tissue. But I have seen in this group of patients, if the disease is only in the thorax and CNS. Of course, if the liver is involved, the positive predictive value is very high for liquid biopsies.
Gilberto, maybe I'll just contribute a perspective from the lab. I think, Dr. Duma's point is absolutely correct. There will be patients where we see differences in distribution between the CNS and the systemic circulation. And definitely CSF is also a very emerging area for profiling of CNS metastasis. On the point of the discordance which Prof. Wyotan mentioned, I think there's also a question of clinical interpretation. In a sample where there are no actionable mutations found, and therefore the possibility of a false negative, actually a non-actionable mutation, like what Prof. Mok said, the TP53, the presence of that at high concentration certainly can actually guide this interpretation towards a true negative. So while non-actionable mutations don't guide treatment, but their presence can make you have higher confidence that the result is real, that it is a true negative. So there are some aspects that can guide, interpretation of liquid biopsy.
Excellent point. And here's another question from Prof. Dunn. Is there a time limit when tissue and paraffin block may not be useful? So is there a time limit when our detection of a mutation in tissue in paraffin block might not be reliable? And I'll ask Min Han to mention and to discuss that one.
For sure. And this is one of the major challenges where sample processing in different labs with different protocols of formalin fixation and storage at different temperatures. And this is a very real issue where you can imagine that globally, right, the protocols and the temperatures and the humidities of how samples are stored and can lead to degradation at some earlier and some later. We have seen samples all around the world, and certainly it's not great when the quality control metrics of tissue samples fail, and that leads to a lot of problems for the patient. I estimate that in conventional practices, 3 years is about okay. We obviously within the year is definitely best for tissue.
Perfect. Then we don't have any new questions in the chat right now. So in the discussion about how to guide therapy, there's a big fork on our decision making today, which is if we do find a driver mutation that we can target, those patients will usually be treated with a specific tyrosine kinase inhibitor or now a KRAS G12C inhibitor, at least in the US. If we don't find any of those mutations, then patients will be treated with chemotherapy and immunotherapy for most patients in the US. Of course, there are variations regionally in terms of the regimen of chemotherapy and which immunotherapy agent is used. And we have a number of trials now validating the use of platinum agents, pemetrexed, taxanes, including nab-paclitaxel, and a number of immunotherapies now, pembrolizumab, nivolumab, as well as atezolizumab and cemiplimab in the US, and there's a number being developed around the world as well. If that's the case, do we have anything in liquid biopsy today, just to complete our discussion in terms of when we just make a diagnosis of advanced disease? Do we have any tests in liquid biopsy today that help us guide which patients will benefit more from immunotherapy? So right now, in terms of practical use, not having a driver mutation that's associated with less of a response to immunotherapy is kind of what liquid biopsy truly help us. So if you have a patient with EGFR mutation, you don't want to use immunotherapy while you don't know that, so that you don't incur in a higher risk of pneumonitis if you start a patient on immunotherapy and then you add on osimertinib, as that has been associated with a higher rate of pneumonitis. For ALK positive patients, we really don't see those many responses with immunotherapy. And then with the more rare mutations, it's a little bit of a different aspect. BRAF patients may have some benefit from immunotherapy, as we have seen both in melanoma and non-small cell lung cancer. Patients with KRAS, especially G12C mutations, do respond very well to immunotherapy as well. But besides that, do we have anything validated today in liquid biopsy to help us guide which patients benefit more from immunotherapy? And I'll ask Dr. Duma first and then Dr. Tan.
Well, I think this comes to discussion of TMB, right? Like we go back and forward about it. I think in ESMO 2019, I think it was Dr. Ramalingam who put like a coffin next to TMB, saying that it was dead, but it keeps coming back. So I think the role of tumor mutation burden, I think, is because the cutoff in many of the studies have varied. Like we haven't married a cutoff yet. And that's what it has been challenging to determine the benefit. I don't make treatment decisions based on a tumor mutation burden. I kind of helps me, but I don't make the final treatment decision on that. And as we know, what is outside of the liquid biopsy, we are a little bit more into the tissue biopsy. PD-L1 is very heterogeneous. There's data from Dr. Mansfield at Mayo that shows that the PD-L1 expression is very different in the primary tumor compared to the metastatic site. So the two markers that we have so far are not great. We work and do the best we can with what we have, but I think the phenotype of the patient also helps you. Is this a squamous versus non-squamous? Because the patient has a smoking history. And if there is no target mutation, the first line therapy in the US is chemo plus immunotherapy. So a long answer to one question, there is no great marker. But we put little pieces together to make the best decision. And finally, we talk with the patient about their preferences, their wishes, and that's the final decision.
Thank you. Minhan, in terms of research, what do we have coming in the pipeline to help us determine if a patient is more or less likely to respond to immunotherapy approaches?
Oh, sure. So I guess the direction of all, a lot of molecular diagnostics research is, in the very short term, it does not look like it's, that there is going to be a great immunotherapy predictor, whether in tissue or in plasma. So the approach in liquid biopsy is to increase the accuracy of detection of the driver mutations. And what looks like the most promising approach at the moment is to profile the TNA, that total nucleic acid in plasma, right? Not just the DNA, but also the RNA. And this is something which has been something of a goal across many molecular diagnostics companies. But it's really an echo of what's happening in tissue, where people are looking at the exon 20 mutations. People are looking at ALK, as Prof. Mok mentioned, which is a DNA RNA combined approach going to be superior to a DNA only and IHC only or whatever. And I think that same conversation is moving ahead in plasma, where traditionally it's been seen hard for CFRNA to take the spotlight, but I think that's changing. And when that happens, I think we'll be seeing more fusions show up. And with that, you will see the increase in the targetable cancers picked up by liquid biopsy. And of course, the immunotherapy patients, everyone's looking for markers, but there really hasn't been anything clear on the horizon yet, whether in tissue or plasma. That's so far my take.
So I do have a follow-up question for you, because RNA is like the new kid in the block, right? And everybody is very excited. Yeah. So should we marry RNA, or should we just date it and then see if something else comes around? Because that's excitement right now. Everybody's like, we do RNA. I just want to show you, this is what we do.
So my personal approach, I'm still getting to know RNA. I have gone out for a couple of dinners, had a little bit of wine, but haven't decided to continue dating it yet. Minhan.
And that's the great thing about any new relationship, right? That the initial passion and the sparks. And yeah, I mean, I guess just getting it out there, getting it into the hands of people and putting it into trials, particularly in fusion positive patients, using this not only in companion diagnostics, but really the natural setting where liquid biopsy really shines, and that's minimal residual disease, that's monitoring, right? Because there is going to be some discordance. It looks like liquid biopsy is not going to be, the perfect replacement in the front line, but there is, monitoring, resistance, and I guess that's really, one of the key topics today as well. So yeah, I guess, yes. Gilberto, that's my take.
We'll definitely get to that topic, and that's a great segue. Just for completeness, there's one thing that you can do in the US outside of lung cancer the FDA did approve the use of pembrolizumab for patients with solid tumors that have TMB high tumors. In lung cancer, we don't think that that helps, as Dr. Duma mentioned, but in the GI and gynecological tumors arenas, this is something that sometimes we do. I wouldn't say it's a great test, but it's something that we can do on occasion. But back to lung cancer, and there's a great question. We do know that about half of the mutations we detect in liquid biopsies actually have a percentage of less than 0.5%. And so at what level, and this is a question from Chi Chen, whom I don't know, hope to get to meet at some point. And the question is, does it matter what the depth of that coverage, of that detection limit is? And how do the tests that we have in the clinic today compare? And Minhan, would you like to take on that one?
Sure. So this detection limit is a real challenge, and it is truly something that's hard to convey in a single number. So the most relevant recent reference is an FDA analysis across multiple different platforms in the United States and China. So the FDA studied several products across different companies, and this is published in Nature Communications, where most technologies find detection below that 0.5% limit actually difficult. And obviously this can vary across the genome, across the gene tested, and one can imagine that for the same test, the detection limit for, say, exon 19 and L858R is actually different. And if you multiply that across the hundreds of thousands of bases being tested, you are looking at a test that has different performance at every base. How do we then condense this into a single number that makes sense to a clinician? I guess I see it as that 0.5% limit, and we have actually worked on some of these topics in the past, which is the difference between a 0.1% and a 0.5% is actually about 20% of patients with driver positive mutations. So you would imagine that at least for a single target, say L858R, a test that has a 0.1% limit and a 0.5% limit, you are going to pick up on average, right, 20% less drivers for that particular base. So this is hard to sort of compare, it becomes hard to compare this across. And I'll stop here because sensitivity is, of course, a topic of great passion among liquid biopsy advocates. There's a lot we can say, but I guess that's the key point, yeah.
And the key point being that the platforms that we have today can definitely be improved, and that's what we're working on in the future as well. And that's why tissue testing continues to be the gold standard, at least for now. We do all hope that at some point we might actually make a diagnosis and a treatment decision based on true liquid biopsy without having to do tissue biopsy. But for now, that's still in the horizon, maybe 5-10 years in the future. Although I can collect stories from many that are not just presenting today, but also in the audience, of patients with poor performance status who are worried about biopsies, that you do a liquid biopsy for somebody that has apparently metastatic disease from lung cancer, on a non-smoker who's older and afraid of doing biopsy. And we have had a handful of people describe cases of people then finding EGFR mutations in particular in liquid biopsies that were then treated with TKIs, with responses, and patients doing relatively well. So it's not impossible. It's not something that we haven't seen. It's just not the standard or the usual approach, but it may become one of the standard approaches, hopefully in the near future. And that brings us to a topic that is at the heart of what both Dr. Duma, myself, and Dr. Tan do as well, which is global oncology. And one of the questions that we had even before the seminar started, how do we get molecular testing and NGS testing to become more broadly available in low resource settings? And I'll ask NJ to start with that, Dr. Duma.
I think most of my experience was for Latin America and some parts of Africa, Equatorial Africa. So having tissue tested with limited number of pathologists that are trained to do FISH, for example, can be very challenging in developing countries. Many of the pathologists have two jobs. They have the government job and they have a private practice job. And they have to, it's very hard for them to be very specialized. So liquid biopsies provide like that extra support and the flexibility of having a sample that can be shipped and they can come back sooner. I'm from a country that economy and political is struggling like Venezuela. And I think the only hope for molecular testing in my country would be liquid biopsies, because tissue with transportation and no gas would be extremely hard to get anywhere. So I think there is future there. Another thing that I think for limited income countries is that these clinical trials that come from a PI in the US or a PI in Asia, they tend to recur these like recurring biopsies or repeat biopsies. I think like the substitution of those recurring biopsies for liquid biopsies, we allow for many patients from other countries to be enrolled in those trials. Because right now the population in trials is very homogeneous. If you have liquid biopsies recommended. The other thing I think is important is that the support that some of these companies may provide to the oncologists at the hospitals in low-income countries, low to middle-income countries, which is send the sample, we take care of it. Most oncologists are overworked and they have very limited resources. And I have to say, it is very easy for me to get a liquid biopsy right now, instead of tracking down tissue for Indiana. That takes way more effort. And as you say, Dr. Lopes, I have patients that I have diagnosed with liquid biopsy that have beautiful responses, and I have monitored them with liquid biopsy. And I have been prepared when you know the progression is coming. You won't change treatment, but you know it's coming in the next scans. So you already start thinking about what treatment you're gonna do, what plan you're gonna do. There's something that we say in Spanish that is, when the soldier is prepared, that's half of the war. So if you are prepared for disease progression, or you have an idea, I think you have more resources for that patient at that time. So I'm a big proponent of monitoring with liquid biopsy, if that's not clear.
We will get to that. Before we do that, I just want to mention two things that hopefully will help us making liquid biopsies more available and molecular testing and targeted agents more available around the world as well. For certain things, you can actually use simple tests as immunohistochemistry. So we, of course, have IHC for ALK. It does not detect all of those patients that might benefit from an ALK inhibitor, but it might detect enough in a way, at least if you have enough tissue. It's a simpler test to do and to train pathologists to do, especially because it's cheaper. So it's about an order of magnitude cheaper than doing NGS. From the technical aspect, I absolutely agree. Liquid biopsies might make it easier for us to have access in certain areas, but the cost is a big issue. For IHC today, we can already do L858R or deletion 19. There are tests that have reasonable sensitivity. And in many different countries, we see it. Here in the US, CARES actually even give us those results. And those are results that we get in 48, 72 hours. So if they come back positive, they help us know that the patient does have a target that we can then go ahead and order therapy for. And we do have developments in places, and particularly in China and Brazil, of homegrown liquid biopsy platforms that by nature of being in those countries tend to be cheaper than what is charged by the companies that do it in the US and Western Europe. So those are very good new developments that hopefully will lead to a democratization of genomic testing in the future as well. There's a topic that many of you have mentioned already. So what's the role of minimal residual disease or monitoring by liquid biopsy once we start treatment? We have emerging data suggesting that if a patient clears their plasma DNA for, let's say, EGFR mutation earlier, those patients do better than if it takes longer or if you don't clear it at all. So are we using that in clinic today? Is that something that you do for all patients? How are you approaching that today, Dr. Duma?
I'm sorry, I just got a text message. Will you mind repeating the question for me?
How are you approaching sequential testing with liquid biopsy for monitoring and for the resistance mechanisms?
Okay, so I do it mostly in patients with the EGFR mutation because that's where we have more data about it, and ALK mutations, which is a big chunk of patients. I don't do them in the first 3 months. It's too early. You're gonna get the same results and pretty much the same number of clones. So when we are approaching the years, when I start doing it, and I do it every 6 months, at least the patient has a concern, oh, you know, there's other clinical characteristics about it. So know right away after the patient has been in the targeted therapy for a while and we have a set of good scans. I think it's also important not to waste resources. If you have a patient that has disease progression in the CT scan, I will not monitor with a liquid biopsy. It's the patient that's like intermediate. You know, those patients that have a little bit of disease progression in one site, but the rest of the disease is controlled, or there's some symptoms that cannot be explained, also helps me.
Perfect. In terms of research, what we do know and what seems to be emerging is that those patients that clear their DNA within 3 weeks or a month seem to do better than those patients that clear in longer time periods. Of course, these are very few patients in just 2 or 3 studies so far, so it's not something that we would use routinely, but it's something that is interesting as well. So in my usual practice, I don't do that as a routine. What we tend to do is if a patient has a progression, of course, you do it at that time. If you're in doubt if a patient has a progression, often patients on an EGFR ALK inhibitor, we have these patients that the disease grows by a couple millimeters, or you see a small new nodule that measures 3 millimeters that was not there before. So you start to get a sense that that patient might lose the response. That's the moment when I do a repeat liquid biopsy now. Because if we do find a mechanism, in the US, we can get either compassionate use or we can get patients to participate in clinical trials. Let's say you have your deletion 19 and then you develop a RET translocation. Those patients might get a RET inhibitor in addition to the osimertinib. And we have a few studies that have shown that that kind of approach does get a response to last a little bit longer. So those are interesting approaches that today are considered research. We will soon see, at least for EGFR, that there will be new FDA-approved drugs based on phase 2 trials showing reasonable responses. Dr. Duma's colleague, Dr. Yane, presented one of an antibody drug conjugate at FASCO, and we also have a double MAT EGFR antibody that seems to be very promising as well. And we imagine that those drugs will be approved in the next 6 to 12 months. They tend to work better in those patients for whom the mechanism of resistance are related to EGFR or MAT. So we will see, hopefully, that coming to clinic. We do still have about 9 minutes and we still have a few questions. To me, the most interesting is not something that we could do clinical in the US until actually a few weeks ago, which is to actually use molecular detection in the blood, in plasma, as a screening tool for cancer. So as you all know, we have been doing screening for cancer in a myriad of different ways for decades. Mammograms for breast cancer, more recently low-dose radiation CT scans for lung cancer, colonoscopies and other methods for colorectal cancer. But of course, we have a number of cancers for which we don't have good screening methods available. And we do know that as cancer is a genetic disease and we do have different methylation patterns or different DNA mutations or RNA, as we discussed, it has been studied in the last few years, and we have a number of different platforms, one of which was actually approved in the US in the beginning of this month. And it's called, the test is called Gallery by a company called Grail. And what these tests have been doing, they are relatively similar. And there's a number of them that have been tested over the last few weeks, over the last few years, I mean. We have PanSeer, you have CancerSeek, and you have another one called Burning Rock. So I don't know who they hired to actually get these names, but they certainly do a good job because they are catchy. And what all of these do is that they look at different methylation patterns or mutation patterns in the blood, and that serves as a screening test. And these have become so good that even if the sensitivity is not perfect, but can range from 20 to 80% depending on the platform and depending on the patient pre-screening risk, but can easily get sensitive specificities of 95 to 99.5% as the test that has been approved. So this is an interesting new brave new world that I honestly don't know how to manage yet, and I would love to hear your opinion. So Grail, the Gallery test, is available with any medical prescription in the US since the beginning of June for about $1,000. So I'm sure that in the next few weeks, we're gonna get a flood of patients that will be getting these tests, and then we're gonna have to work it out. So I would love to hear your opinion on those tests and where we're going with it.
So I'm going to start saying that when you order a test, this is something I learned very early on. When you order a test, you need to do something about it. You know what you're ordering the test for. So I think phishing can be very challenging. And as Dr. Mok mentioned in his talk, some knowledge can be confusing and can be unnecessary. So there's an abstract that was presented in ASCO 2020 about NGS and how the patients understood their NGS results. It's from Australia. And there was a very big disconnection between what the results meant and what the patients understood. And for some oncologists that train before molecular testing, the results are even confusing. So now we're adding with this fission. So what if you find a T53 mutation? What is going to happen to that patient? The level of stress, expenses, are you going to CT scan that patient every year head to toe? So I think it is interesting, but it is a risk. And there's an ethical concern associated with that too. So I would say maybe too soon. And I'm worried about the consequences in the healthcare system. And I'm worried also about what are we going to do with these patients? The level of anxiety, like the level of anxiety or a breast nodule is very high. What if you have a T53? Like there's articles about people writing how they feel after they find out. So I don't know, it brings me more concerns than solutions.
Minhan?
Yeah, so I see this.
I think Minhan froze. Tech team, can you guys hear me?
I can hear you.
You can hear me. So I guess we are on, and I guess the participants are on. So as I take on the discussion until we see, thank you, Anastasia, for letting us know that everybody can hear us. So one of the main problems with the platform, especially the ones that have been approved already, is that we only know the very basics of it. So we only know what the sensitivity and the specificity of the test is. Of course, we would know what the positive predictive value is, and that is not high enough today to tell us that everybody should get it. It certainly should be guided by patients' pre-test risk. And this is the biggest problem. What is the comparison of these tests with our current screening tests? Is this going to lead to so many diagnostic tests that will then increase risk of dying from a complication? If you're only screening a few patients, this is usually not a big problem. But even colonoscopy screening can be risky, as 1 in 10,000 or 100,000 patients can have worse complications than what you would get without doing the screening. So this is something that will develop in the next few years. It's something that in the US, it's extremely interesting because the test is approved. So we're gonna see this develop live as we move forward. So Minhan, I think we got you back. Can you hear us now?
Yep, I'm sorry. I may have missed the last 1 minute, but I'm not sure whether I can still answer the question on screening if that works.
Please go ahead. Yes.
Perfect. So I guess we started, the webinar on late stage cancers. We have the topic on the screening of the asymptomatic, and as Dr. Duma has correctly said, there are many ethical challenges, many interpretation challenges around the asymptomatic, but there is a big broad group of people in between, and even in the MRD group, we know we have the patients, being monitored on immunotherapy. We have the patients post resection being monitored for recurrence. We have the patients post first line for resistance. So I'm going to say that there is that goal to pick up patients who are asymptomatic, but I think the much more important group to focus on in the short term will be the high risk patients, the smokers, and this is where methylation and other aspects of cfDNA, cfRNA can come together for a better stratification tool. Yeah, there is going to be a lot of the use of methylation, not only in the screening of the asymptomatic. I expect that this will happen in the evaluation of recurrence and MRD. So, but how these happen, because methylation is a very different signal from mutation. The best way to think about it is that methylation is an analog signal. It's not a 0 and 1 signal. And if methylation isn't a 0 and 1 signal, how do we communicate and upgrade and create those right thresholds for people to interpret? And in another test, we all know oncotype in another cancer, another application, how difficult and how long that process was in communicating thresholds in a continuous signal. So I guess that's my take. It's coming, and I believe education and research is the answer to introducing this to clinical practice.
Perfect. Thank you, Minh-Han. We are approaching 9:30 p.m. in Miami, 9:30 a.m. in Singapore, and we're coming to a close. One of the questions was where do we see liquid biopsies being in 5 years? So I think that we're going to have a much bigger role than we have today. I think we will use it as a diagnostic tool as well. In some cases, may even preclude biopsy in situations like patients with EGFR mutations or ALK alterations that are very specific of a certain tumor. I think we will use it more often to see which patients we will need to consider something else beyond the just usual TKI. So let's say somebody on osimertinib who doesn't clear their plasma EGFR in 2-3 months. Is that somebody that we should add something? If we don't find a specific mechanism of resistance, should that patient get chemo? And I hope that we will see those trials coming up soon. And that should be true as well in ALK and the less common mutations. I think that we will be using liquid biopsies a lot more often to detect resistance mechanisms in all of these unusual mutations as well as in the common ones. And I do see it becoming something that we use in the adjuvant setting as well, hopefully selecting which patients might truly benefit from adjuvant treatment. I'm going to stop here to give Dr. Duma and Dr. Tan a minute or 30 seconds or so for them to give us their final words.
I think liquid biopsy is here to stay. We're learning more. I think there's future for continue to monitor response to therapy and offers an opportunity when there was no opportunities before. How many times have we received a call saying we ran out of tissue? So so common, I should make t-shirts that says do FNAs in my patients. But it is common, and liquid biopsy has rescued me many, many times.
Absolutely. So, Minh-Han, any last words?
I guess, I'm a believer that liquid biopsy will change practice in so many different ways. It gives us all a new insight, but I also want to sound a note of caution in the sense that if we look at another new technology in the past, the PET scan, we see its application and its growth in helping patients, profiling patients. We also saw that the difficulties in research and the introduction into guidelines, and that also took a while. But we also see today how much it helps the patient and the physician do a better job in applying the right treatment to a patient, and hopefully in the future in early screening. So I guess that part is also something I'm very mindful about, which is education, adoption, learning, and that will come together with great technology.
Thank you. And a special thank you to all of you who have been listening to us for the last hour. Looking forward to staying in touch and hopefully meeting in person as COVID becomes history. Have a good day and a good night, everyone. Hope to see you soon.
Bye, everyone.
Thank you.